recent advances in HER2-positive metastatic breast cancer management. It gives me great pleasure to invite our first speaker, Dr. Prabhat Bhargava, medical oncologist from Mumbai. Over to you, sir.
Just give me 1 second, just opening my slide. There is some problem with my laptop today.
Sir, if you need, we can share the slides from our end, sir.
Yeah, if that would be better.
Sure. Sophia, please do the name. So requesting you to say next whenever you want us to move to the next slide.
So, good evening, one and all. I am Dr. Prabhat Bhargav, medical oncologist and professor of medical oncology at Tata Memorial Hospital. Sorry for the delay. So, point of the discussion today is the management of HER2-positive breast cancers, especially metastatic breast cancers, and how things are changing in recent times. Next slide, please. So, my flow would be introduction of HER2-positive metastatic breast cancers, unmet need in second line, recent advances in terms of using the data available for Trastuzumab, deruxtecan, neratinib, tucatinib, and what would be current treatment algorithms for HER2-positive metastatic breast cancers, and take-home messages. Next slide. So, coming to HER2-positive breast cancers. Next slide. We all know that roughly 30% of your breast cancer patients will become metastatic at some given point of time. And HER2 is roughly 20% of all the breast cancers. HER2 is roughly defined by IHC as 3+, or if IHC 2+, then HER2 by gene amplification by fish should be, or dish or fish should be positive. Next slide, please. Next. So roughly the majority are HER2 ER positive also, and very few of them, 7% are HER2 hormone negative also. So HER2, the finding of HER2 discovery of HER2 has drastically changed the management of HER2 positive breast cancers. We will see in today's slides, subsequent slides. Next slide. Next slide. We have to keep in mind that we have to use our best therapy as upfront as possible. That is, in first line itself, roughly say 22%, 1/4 of your patient will not receive second line of therapy, and roughly 1/3 of your patient will not receive third line. So keeping our best therapy for second line or subsequent lines, third line does not make sense. We have to use our best therapy upfront. Next slide, please. So first line, we all know Cleopatra trial since years, that if you add pertuzumab to the backbone of docetaxel or paclitaxel plus trastuzumab, you will give a median OS benefit of roughly 16 months to your patient and PFS benefits of roughly 6.3 months to your patient. And next, and when you give second line, till now standard of care was capatinib TDM1, which was based on the Emilia trial, where 991 patients were enrolled and divided, randomized into TDM1 or capecitabine lapatinib, and TDM1 was easily tolerable with PFS benefit of 3 months and survival benefit of 5.8 months. Next. But things are going to change. We should keep in mind while interpreting Emilia that at the time of Emilia, Cleopatra was ongoing. So most of the patients in Emilia trial, that is in second line, did not receive pertuzumab as first line therapy. And the subsequent PFS, OS and PFS decreases from 12 months PFS to just for 6.4 months on 9.6 months with TDM1, and OS also decreases subsequently. Next slide. Similar to what I was saying in OS. But if we interpret that majority of patients did not receive pertuzumab in Emilia trial, in real world setting, if we treat patients who have received pertuzumab, The Italian real-world evidence of 250 patients shows that those who were exposed to pertuzumab in first line, their PFS was only 3 months in second line. A second real-world evidence from Italian of 370 patients also shows that it is just 6 months rather than 10 months who are pertuzumab naive. And other evidences also show that in real world it is 6 months only, whereas in Emilia we had seen just now that it is 9.6 months. So in pertuzumab pre-treated patient, we have to think beyond TDM1. Next slide. So TDM1 is a drug conjugate where antibody trastuzumab has a drug conjugate attached to it with a membrane permeable linker and impermeable linker, and that is why the drug goes inside and then the linker is broken down. So there is no bystander effect seen with TDM1. Next slide. But when we come to deruxtecan, which we'll see in today's talk, the recent advances beyond TDM1. Next slide. So advances is as follows. In 2019, trastuzumab deruxtecan came in second line. Then TKI combination of tucatinib and neratinib have come. Then margetuximab have come over a period of time. Next slide. Next. So how different is trastuzumab deruxtecan than TDM1? So deruxtecan has a highly potent top isomerase inhibitor payload. The the linker is cleavable, and the drug load is 8:1, high drug ratio to the antibody ratio. So it gets cleaved even outside the cell, and thereby it causes bystander effect to even HER2 negative cells besides the HER2 positive cells available. So this cleave, or if it is cleaved inside, then obviously the drug is released inside the cell and thereby leading to cell death. Next slide. Tabulated difference between TDM1 and TDX is as follows. TDX has topoisomerase 1 inhibitor as the drug, whereas in TDM1 it is M-tensin, which is anti-microtubule inhibitor. The drug ratio to the antibody is 8:1 for TDX. That is more amount of drugs available for each antibody has more amount of drug compared to only 3.5 times in TDM1. Both have a cleavable linker is there in TDX, but it is non-cleavable in TDM. And thereby there is bystander effect of TDX and no bystander effect with TDM. Next slide. So coming to Destiny 01 trial, that is the first trial to see the evidence of in a randomized, in a non-randomized fashion to see evidence whether TDX works in patients who are refractory to TDM. In this, patients were brain mets patients were also allowed, and patients were randomized to the 3 dosing at 5.4, 6.4, and 7.4. When 5.4 was the dose finding was found out, and 6.4 were taken forward, and 5.4 was found to be useful. And so 184 in the part 2, 184 patients were enrolled at 5.4 milligram per kg. Next slide. Their primary endpoint was overall response rate, and the secondary endpoint was overall response rate by investigator, the disease control rate, disease overall response rate, and clinical benefit rate, PFS, OS. Next slide. So baseline demographic and clinical characteristic of all 184 patients, as in real world, you will see that they are roughly 50-55 years of age, almost all were 100, one-third patient from Asia, North America, and Europe. With good performance status and hormone receptor positive, as most of the patients will be hormone receptor positive. 50 patients, majority were IHC 3 plus, but some patients were even IHC 2 plus and 1 plus. 15% of the patient. Visceral disease was present as we expect in HER2 to be more aggressive in 91%. Good amount of 13%, approx 10% were having brain metastasis also at the time of diagnosis and at the time of enrollment into the trial. Next slide. Next slide. Yeah. So you will see here that most of the all patient had received TDM, and 2/3 of the patient had received pertuzumab also. Other anti-HER2 directed therapies, that was because they were pre-treated with multiple lines. So half of the patient had other anti-HER2 therapies also, hormone therapy in half of the patient, other systemic therapy, almost other systemic therapy in 100% of the patients. Progressive disease as best response in 1/3 of the patients. So those refractory to everything were enrolled in this Destiny 01 Best 01 trial. Next slide. In spite of the so much pre-treated patient, the overall response rate was 62%. As you can see from this waterfall plot, hardly any patient had progressive disease as the best response, and median duration of response was 18 months, which was unheard of till in refractory patient. We saw the even with Cleopatra first line, we see a response progression-free survival of 18 months. And median time to response was just 1.6 months. So within 1.5 months, patient will start responding. Next slide. And across the subgroups, those who had the overall response rate was roughly 60% for all patients, whether they had received pertuzumab or not, whether they were hormone receptor positive, negative. Those who were negative, obviously they did respond much. It was to the tune of 70%. Those who had brain metastasis also responded to the tune of 60%, irrespective of their ethnicity, their ECOG performance status. Those who had HER2 1 plus or 2 plus, their response rate was 50%, which is also way beyond what we will see in real world without any TDX. Next slide. Next slide. The median duration of response is 18.2 months. Next slide. Median progression-free survival in relapsed refractory patients also was 19.4 months, which is way beyond better than what we saw in Cleopatra, even in first line of 18 months PFS. Next slide. And median overall survival in this refractory patients reached up to 29 months. So you can imagine what difference it made to survival of such patients. Next slide. In those who had CNS involvement, over there also median duration of response was 16.9 months, and the response rate was overall response rate was 58.3%. Next slide. Treatment related adverse event were grade 3 new CINV, a drug and antibody. We normally don't expect CINV, but this has grade 3 CINV also in roughly 10% of patients, and grade 1, grade 2 in roughly 70% of patients. Then neutropenia, because of higher drug load, there is neutropenia also. This may not be as easy as Trastuzumab and TDM1 that we are used to giving very casually nowadays. Fatigue was also there, anemia is also there. So you do see myelosuppression and chemotherapy related side effects also with this drug. Next slide. And ILD, which we were very skeptical about. So ILD is seen grade 3 is only in 1%, one patient out of 184 patients. So out of 200 patients, roughly 0.5% will have the side effect of ILD grade 3. But grade 1 and grade 2 was also fine. Grade 1, but if we are very cautious on our day-to-day CT scan that we will be doing of such metastatic patients, we may stop the TDX or temporarily switch on to other medicines, Trastuzumab, till they have grade 1. And once they resolve it from grade 1, grade 2 to less than grade 1, we can restart TDX for such patients. Next. Coming on to second line scenario where we saw Emilia trial. Here we have Destiny 03 patient 03 trial where 524 patients were randomized to 1:1 patient to TDX at 5.4 milligram per kg or TDM1 3.6 milligram per kg. They were stratified according to hormone receptor status, prior treatment with pertuzumab, and history of visceral disease. They beyond the second line were also allowed in this patient, and not just second line. So beyond first line, everybody beyond first line were allowed. Next slide, please. So inclusion criteria was age more than 18 years, pathologically documented HER2 positive breast cancer, who have radiological progression on previous line of therapy, and had adequate hepatic and renal function. The patients who were excluded were those who had anti-HER2 ADC in metastatic or adjuvant or neoadjuvant setting, and disease progression within less than 12 months, uncontrolled or significant cardiovascular disease, medical history of ILD or pneumonitis, and spinal cord compression or active CNS metastasis that are untreated and or if patient was symptomatic. Next slide. So roughly 700 patients were screened, and 524 out of 700 itself were enrolled. 2:61 at the TDX arm and 263 in the TDM1 arm. At the data cutoff, also roughly 75 patients were still ongoing in TDX arm, and in TDM1 arm only 18 patients were ongoing. Those who had required treatment withdrawal by patient were 7%, so slightly higher than 5% which was seen in TDM1 arm. And for physician decision, only 1% required treatment. So if we are very careful, then due to physician discretion, only 1% required treatment withdrawal, and compared to 3% in TDM1, which we think has only thrombocytopenia as a side effect. Next slide. The median baseline characteristic, median age 55 years, most of them were female, roughly more Asian, predominant Asian population in this cohort of patients, with white around 1/3 of patient and Asian 60% roughly in both the arms. Next slide. Majority were HER2 3+, strong positive, hormone receptor positive in 50% of patients. Again, brain mets were allowed, so 20% of the patients in both the arms roughly had a brain metastasis, and visceral disease were present in 2/3 of the patients. Next slide. Pertuzumab was allowed in 60 as so roughly 60% in both the arms had received pertuzumab to begin with, where the time of enrollment in the study. And previous line were only one line was received in only 40%. So even in this trial, there were 1/3 of patients who were beyond 2 lines, 16-17% patients who were beyond 3 lines, 4% of 5% of the patients beyond 4 lines, and beyond 5 lines patients were also there in more than 10% of the patients. Next slide. The progression-free survival with TDM1 was just 6.8 months because pertuzumab was also allowed. In pre-treated pertuzumab patients were also there in up to the tune of 60%. But as we would have expected, seeing at Destiny-01, more than 20 months of PFS was expected, and we see that PFS reached 28.8 months, which was survival in Destiny-01. So you can give a progression-free survival of roughly 29 months to your patient in second line if you give TDX compared to just TDM1, especially patients who had received pertuzumab in first line of therapy. Next slide. The progression-free survival as per subgroup, you can see in all the subgroups, the hazard ratio is towards less than 1. Whether patient was hormone receptor positive, whether patient received pertuzumab, whether he or she was in visceral crisis, and more number of the previous systemic therapy was there. In fact, it was favorable towards TDX rather than TDM1. Next slide. The overall survival till the cutoff has not reached, but it starts from 40.5 months to not evaluable, and for TDM1 it is 34 to not non-evaluable, with an hazard ratio of just 0.6 and p value of 0.0037. Next slide. Say for the forest plot for OS, also you can see it is hardly crossing unity, especially in patients who had received prior pertuzumab. For them, otherwise it is hardly crossing per unity. So in all subgroups, you can prefer TDX. Next slide. The secondary endpoint, PFS by investigator assessment, was also 29 months. So whether both central and investigator initiated is almost the same. Next slide. The anti-tumor response, as the waterfall plot itself is saying, in TDM1 there were few patients who were best response was progressive disease, but in TDX hardly any patient had best response as PD. Most of them had CR or PR as the best response, majority. Next slide. Overall response rate was up to the tune of 8 please. Overall response rate was just 35% with TDM1. It increased more than double to 78.5%. CR in metastatic patients was up to the tune of 21% is astonishing. And duration of response was 36 months compared to only 23 months in patients who were receiving TDM1. Clinical benefit was seen in 90% of your patients compared to only half of patients in TDM1. Next slide. Median PFS2 was also as in investigator was 40 months compared to TDM1 it was only 25.7 months. This will include the patient who had crossover to TDM1 post TDX. So combined after TDX also you can give TDM1. You saw the PFS1 was roughly 29 months, and after giving TDX TDM1 the PFS is reaching 40 months compared to giving TDM1 followed by TDX. Still, the PFS did not match what if you give it in previous line TDX. In spite of crossover, you see that there is inferior PFS2 in the TDM1 arm. Next slide. The overall safety summary Any grade treatment-related adverse event were roughly 99.6% in TDX, and TDM it was to 95.5%. But grade 3 is 50% in both the arms, whether you give TDX or TDM1. Serious treatment-related adverse events roughly seen in 1/4 of your patient, even with TDM1 and TDX both, and requiring drug discontinuation in 21% of patients in TDX, but only 9.9% in TDM1. Next slide. Most common treatment-related adverse event in more than 20% of the patients were anemia, because there is myelosuppression will be seen as there is the heavy drug load. So grade 3 anemia in 9% of patients, 7% will have thrombocytopenia, roughly 6% will have neutropenia or other WBC related. Nausea is seen in 7% of patients, vomiting in 1.6%, and diarrhea in just 1.2% of the patient. Fatigue in 6% patients, and decreased neutrophil count in 16% of the patients. So there is good myelosuppression in less than 10%, and nausea and vomiting in less than 10% of the patient, and fatigue in 6% of the patients. Next slide. So adverse event of special interest, that is the ILD or pneumonitis. Again, in this trial, ILD grade 1 was only 4.3%, grade 2 in 10%, and grade 3 less than 1%. So grade 3 meaning where patient's life will be hampered, quality of life will be hampered, is seen in only 0.5 to 8.8% if we do careful monitoring of ILD or pneumonitis, as we would be doing a CT scan for such patients for seeing response assessment. So that will give you an idea. If there is any pneumonitis, signs of pneumonitis, we can stop the drug as early as possible. Decrease in LVEF with TDX is almost slightly more the TDX compared to TDM1. It was 3.1% of grade 2 LVEF, which was only 0.4% with TDM, and grade 3 is the same. Any grade is slightly, that is why any grade comes to numerically more than TDM1. Next slide. So outcome of ILD or pneumonitis was fatal in none of the patients. 15% patient did not recover till the time of analysis, but most of the patients did recover or were recovering. So it does not seem to be a significant event which will be hazardous or fatal to patient with TDX if we don't monitor it. If we do monitor it regularly. Next slide. So in conclusion, as per the updated OS analysis, clinical meaningful and strategically significant improvement in OS was seen compared to TDM1. The TDX significantly reduced risk of death by 36% compared to TDM1, and median PFS with TDX was significantly longer with TDM1, 28.8 months versus only 6.8 months with TDM. 78.5% of patient experienced a confirmed objective response rate, and roughly in 21% there was a CR. And consistent OS and PFS benefit was observed across key prescribed subgroup. Being a longer treatment duration, TDX continues to show a manageable and tolerable safety profile. Next slide. Coming on to other options, tucatinib is an upcoming drug of TKI not yet available in Indian scenario. Next slide. So HER2 climb was presented recently. What they did was HER2 compared trastuzumab capecitabine to trastuzumab capecitabine and adding tucatinib, that is adding TKI to existing anti-HER2 antibody with a chemotherapy drug also. Here also previously stable brain mets were allowed, untreated brain metastasis who were not needing local therapy, and previously treated but progressing brain metastasis not needing immediately local therapy were also allowed. They were randomized to 2:1 patient, 410 patient to active arm, and only 202 patient to placebo arm. Next slide. The PFS was 46% better compared to not using any TKI. Overall survival was 34% better by not using any TKI if you use TKI, and PFS by investigator was also 52% better. Next slide. So in HER2 climb, the overall response rate was 41% compared to only 23% just without adding TKI, and PFS was 7.8 months. That is roughly similar to using TDM1 compared to just giving CAPE lab, and only 4.9 months if you give CAPE trastuzumab. Median OS reached just 21.9 months compared to 17.4 months with capecitabine plus trastuzumab. So adding a TKI like tucatinib is an option where patient cannot afford TDM1 and you want to give Trastuzumab and a drug. So capecitabine and Trastuzumab plus TKI can be an option if patient for some reason is not fit for TDM1 or TDX or not affording for them. Next slide. Those who have brain metastasis, over there also tucatinib, because TKI is a better brain penetration. So median PFS was 7.6 months compared to placebo of 5.4 months. And without brain metastasis, obviously PFS was better, 9.6 months compared to 6.8 months in the placebo arm. Next slide. Intracranial overall response rate was 47% compared to only 20% if you don't use a TKI. So there is good brain penetration and good response in the brain and PFS in the patient who have brain metastasis. Next slide. The triplet had median CNS PFS of 9.9 compared to only 4.2 with doublet. And those who have active brain disease, over there also it was 9.5 months compared to only 4.1 months. And those who have stable brain disease at the time of enrollment had a good PFS of 13.9 months. Till now, I did a retrospective analysis data, it was only OS was 13 months. So if we are able to use new drugs, you can achieve a PFS of 13.9 months compared to placebo, it was 5.6 months. Next slide. Adverse event of adding a TKI will obviously grade 3 diarrhea in roughly 13% of the patient, palmoplantar erythema in roughly 13% of patients, increased nausea compared to TDM1, hepatotoxicity more with TKI compared to Trastuzumab and capecitabine of 10 versus 1%, fatigue, increased fatigue, and increased stomatitis. So it does come at a slight increased expense of in terms of side effects compared to the benefit that you get, modest benefit that you get. Next slide. Neratinib is again another TKI. Next slide. Where we know that NALA trial were compared head-on to capecitabine, and they feel neratinib is better. Let's see what were the results. So 1:1, they were randomized to capecitabine versus neratinib. At neratinib was given 240 milligram per OD, and capecitabine dose was reduced to 750 milligram per meter square, and a loperamide prophylaxis was given because there was good amount of diarrhea. Next slide. So what they saw that overall response rate was 33% compared to 27%. Patients were more than 2 lines of therapy here. So PFS was 8.8 months compared to only 6.6 months if you give capecitabine, and median OS was 24 months, slightly better than 2 months better in PFS and OS compared to capecitabine. So it seems to have more potent drug compared to the age-old lapatinib that we are used to using. And being more potent, obviously grade 3 side effects, that is diarrhea was more 24% compared to only 30% in capecitabine lapatinib. Next slide. Safety data, we all know that 24% had diarrhea and nausea was also slightly increased. Palmoplantar erythema was less compared to lapatinib and capecitabine, maybe because the dose of capecitabine was less and vomiting was slightly more. Next slide. So current treatment algorithm would be, next slide. First line, obviously, till now is pertuzumab plus trastuzumab plus a taxane, which can be either docetaxel or paclitaxel. TDM1 as per Emilia trial, but if we go with Destiny Breast 03 TDX, and we will shift to third line TDM1, the TDM1 will still work after TDX, or you can give one of the TKIs added to the ongoing trastuzumab plus capecitabine. Next slide. So similarly in NCCN also, we can see that deruxtecan has entered second line therapy. Third line is tucatinib plus trastuzumab plus capecitabine or TDM1, and rest of all therapy have gone to fourth line. Next line. So take home messages. Next. Between first line THP and second line TDM1, the median PFS drops numerically by half, demonstrating that more effective treatment options that further delay progression and survival are needed in second line. So a trial, next slide, next was done of TDX, where patient TDX were given as standard of care as after initial therapy with multiple more 3-line options, and there are other options in third line for neratinib, tucatinib, and margetuximab are available. Next slide. That's it. Thank you.
Thank you so much, sir. I would now like to invite our next speaker, Dr. Udip Maheshwari, medical oncologist and hematologist from Mumbai. Over to you, sir.
Hello.
Yes, sir.
Yeah. Can you hear me?
Yes, sir, we can hear you. So your mic is on mute, sir.
Mute. Stay. Yeah. So can you go to the next slide? Yeah, so we'll be covering this side effect profile in this following order. We'll see the introduction of Trastuzumab. I think has been already spoken in the last talk. Safety profile of TDXD with respect to nausea, vomiting, hematological toxicity, alopecia, interstitial lung disease, pneumonitis, and left ventricular dysfunction. Can we go to the next slide? Yeah, next. Next, please. We know so coming to directly to Trastuzumab deruxtecan, we know that it is three basic molecules that are there: HER2 IgG antibody, there is a linker, and there is a topoisomerase 1 inhibitor. And we also know that it is having a payload mechanism of action where topoisomerase 1 inhibitor is delivered into the cells in a targeted fashion, and it has high potency, high antibody drug ratio, short systemic half-life, and a stable linker. So, and also the lastly very important is the bystander effect, which we'll discuss. Next slide. Again, so how the process is, it attaches to the HER2 receptor, goes inside the cell, the linker is cleaved, payload is delivered to the nucleus, and that causes cell death. And from that, there is also transmembrane permeation of the payload, and it goes to the other surrounding cells as well. And that is where it works in HER2 low disease. And this bystander effect is very important in the mechanism of action of trastuzumab. Next slide. So we've seen this Destiny 03 trial. We'll move on to the next slide. We know the results also. Can you go on to the next slide? The dose was 5.4 mg per kg with a good PFS advantage. Next, I'm not going to discuss these slides here in detail because it's already been spoken about in the last talk. Next. Again, so secondary endpoint of OS also, there is a separation of curve with a HR of 0.55. Next. So we have around overall response rates. If we see that 21% CR rates versus TDM1 where only 10% CR rate, so definitely there is a outstandingly better treatment option as compared to any other HER2 targeted therapy. Next. Evidence of safety on testosterone we have seen. Next slide. So we know that largely the TDXD had similar side effect profile than TDM1, excepting serious tries that was slightly more, and the discontinuation because of TDXD was slightly higher. Next. Again, overall drug-related safety profile, if you see, the numbers are slightly higher. Any drug-related effect were 98% versus 86%, which is higher, and any grade more than grade 3, it is 45 versus 39.6. Serious side effects were 10.9 versus 6.1, and led to discontinuation of the drug was 12.8% versus 5%. So definitely there were more incidences of adverse events, and that is why we are having this talk wherein how to manage these adverse events is a priority. The commoner ones, were the ILD or threatening ones were ILD, when 8.2% versus 2. In the TDXD arm, it was around 8.2%, and also, most common trial associated with dose reduction was nausea, vomiting, and neutropenia, and they were also commonly seen. So, myelosuppression and ILD and left ventricular function going down were the 2 or 3 most common side effects that were happening. Next. Again, the drug-related trial, nausea, vomiting was highest. Then there was fatigue, vomiting, neutropenia. These were slightly on the higher, and if you see the grade 3 side effects were more neutropenia, which was very common. Okay, next slide. Okay, so adverse events of special interest were ILD, LVEF, and so if you see the number, any grade 27 versus 5, which is a good number, and even in LVEF you see 7 versus 1, which is also a higher number in case of TDXD, and we'll have to monitor these things as we go ahead. We'll move to the special side effects in the next few slides. Next slide. Correct. So management of these adverse effects, we'll come to it one by one. Next. Yeah, so management of adverse events may require temporary interruption, dose reduction, or treatment discontinuation of trastuzumab. And we do not re-escalate TDXD dose ever once a dose reduction is made. So there are 3 dose reductions that they have given. The first dose, obviously, we know 5.4 milligram per kg. First dose reduction would be to 4.4, and the second dose reduction would be to 3.2. So these are the step dose reductions that are there in TDXD. Next slide. Now, obviously, an MDT really helps when we are using a TDXD where experience into clinical practice is less for these new drugs, and obviously a multidisciplinary board or tumor board may help in managing these patients better. Next. So, multiple factors would be considered in, treatment decision making. The efficacy of the drug, which is obviously better, patient choice and quality of life, which, we may have to choose patients who have poor quality of life or elderly, who have issues with already, lung pulmonary issues, some pneumonitis or COPD. We'll have to select out those patients and family history of any disease, those patients' comorbidities, safety, and patient support in care. So all of these factors, multiple factors always, as we usually do for most of the drugs, would be required and should be looked at very keenly before starting this drug. Next. So discussion, obviously, counseling of patients is very important, wherein we should, before starting, first, it's an expensive drug. Second, it has side effects. And third, the efficacy that it has shown. All of these need to be discussed with them. And even what side effects in detail should be discussed, as in what should they watch out for when they do the therapy, and what should they report is needed to be discussed with them prior to starting this, because if they miss some symptoms and they don't report to you, then it may go into higher grades and will probably in fact, even the grade 5 side effects happening with ILD in such patients. Next. So before TDXD, we should be telling our patients about neutropenia, about the side effects, and also there are basic management guidelines for all nausea, neutropenia, ILDs, alopecia, fatigue, and there is decreased LVEF. So all of these side effects, we have basic management. We know antiemetics. We have GCSF prophylaxis for neutropenia and prophylactic antihistaminics for infusion reactions. Alopecia, we can use scalp cooling. And fatigue, obviously, we'll have to assess history and see which patients are prone to it, right? So that we'll need to see. And yeah, so next slide. Coming to the first very common side effect, which is nausea, vomiting, which is pertinent. And next, TDXD has been labeled as highly emetogenic in the NCCN group, wherein next slide, wherein it has gone to more than 90%, more than 90% label, and it is next slide. So we see grade 3 nausea, vomiting happening in more patients, 18 and 4 in TDXD, which is higher than what has happened with TDM1. Next. Again, if you see the NCCN guidelines, TDXD has been entered into the high emetic risk, that is more than 90% frequency, which I was talking about. And probably we can use a preferred option A, wherein we can give a 4-drug regimen, and that can help. And so that reduces, that has shown, in fact there are trials where they have shown that this does help reducing the nausea, vomiting. Next slide. There's one more slide. Yeah, so these are the chemotherapy induced breakthrough nausea vomiting drugs, wherein we can use, there are alternatives to it. One olanzapine is the preferred one, wherein we use the classical triple drug regimen for nausea, and we can add the 4th drug as when there is a breakthrough vomiting. Then there are other lorazepam. I tend to add lorazepam in patients who usually have breakthrough nausea vomiting, which we used to do in hematological malignancies, or even in transplant patients where the high dose regimens were given. Lorazepam did work well there. So I think this is a drug which we can use. We don't often use in solid cancers, but yes, this can be used. And there are other prochlorperazine, haloperidol, metoclopramide, dolasetron, granisetron. These all can be added to the anti-emesis profile, and that helps usually, and vomiting can be controlled. Next slide. So again, before TDXD, we do give antiemetics. Then we give the infusion. Dexamethasone can be added, or a 5-HT3 or olanzapine, whichever drug we have not used in the first regimen can be added. So it says the same. And there's also one institutional experience of 10 patients wherein adding NK1 receptor antagonist, that is aprepitant to ondansetron dexamethasone pre-medication, resulted in decreased nausea vomiting, that we all know, and it's a known fact that these 3 drugs work well together. Next. So also with other things, we'll have to give them a basic basic instructions of what needs to be done. Small meals, avoid foods that can cause nausea, sit upright, eat food at room temperature, drink plenty of water. Dietitian, specialist nutrition, alternative treatments can be taken, lie on the side so that they avoid aspiration. Frozen liquids such as ice chips, and these are all the basic care that we usually tell our patients post chemotherapy, and these can be followed here. Counseling for nausea vomiting. Next. Going to the second thing, which is hematological toxicities, which is also a concern with TDXD1. Can you go to the next slide? If you see, next slide. If you see the rates of grade 3 events, neutrophil count, white blood cell count, it is significantly higher, 16 versus 3%, which is higher. And grade 3 TDXD1, 5 mg per kg, there is almost around 34.4% patients reported neutropenia, and 16.3% had grade 3 or 4 neutropenia. So these are higher, obviously, and we know how to manage neutropenia. Most of these patients would require a prophylactic GCSF, and that needs to be given. So, and febrile neutropenia needs to be treated with simple guidelines. Can you go to the next slide? We'll see in the next slide. I think so. Next. Yeah, so grade 3 or more side effects interrupt TDXD until you go to grade 2. Grade 4 interrupt TDXD to until grade 2 and reduce dose by 1 level. Any grade 4 you'll have to interrupt and reduce dose level. And in case of febrile neutropenia, interrupt TDXD until febrile neutropenia is resolved and reduced by 1 level. So these are the 3 things. Grade 1, grade 2 neutropenia, we don't need to reduce, and even grade 3 neutropenia, we don't need to reduce the dose. Rest all grade 3 will need to interrupt and reduce the dose. So neutropenia is the only thing where in even grade 3 neutropenia we don't reduce the doses. Next slide. Next. Again, if you see anemia, we can use red blood cell transfusions, erythropoietin. Standard regimens which we use for most chemotherapy. Leukopenia, we use antimicrobial medication, GCSF, and for thrombocytopenia, we can use transfusion, corticosteroids, and reduce the dose. Next. Again, so if there are again these dose reductions which are mentioned, anemia, we can delay the dose grade 2, then maintain the dose less than grade 2, and in grade 3 or more, we need to reduce one level. In all three, probably. Only in leukopenia we don't have in grade 3. And if they say that if the neutropenia resolves within 14 days from the onset, then we can maintain the dose. If it is more than 14 days it takes for recovery, then we can reduce one level. That is what they say in leukopenia. While thrombocytopenia, again, if resolved within 7 days from onset, you can maintain the dose. If it takes more than 7 days, then you can reduce the dose to one level. And once you reduce the dose, you should not upstep it again, right? That is the guideline. Next. Alopecia, again, it is hello. Yeah, so alopecia, again, it is grade 1, grade 2. If you see, there are high rates of alopecia, 39.9% versus 0.2%. So alopecia can be a bothersome thing in this. Next with TDXD, we can use next slide. We can use scalp cooling systems, which does help in reducing the alopecia rates. In fact, there are data that, not with HER2 per se, but with even anthracycline and taxanes, there are data of preservation of hair in about 50 to 55, 60% odd patients also. So that does help. And scalp cooling, although there is currently no data to support scalp cooling for HER2, but it does help in other cancer subsets. Yes. So next slide. We know that scalp cooling should be done 20 to 30 minutes prior to infusion, during infusion, and almost about 20 to 30 minutes post infusion, 30 minutes to 1 hour post infusion. So that needs to be given, and that helps in two ways. It reduces the metabolism of the hair follicle and also reduces the capillary flow or the flow to the scalp, blood flow to scalp. Correct. So that way we can help these patients reduce the alopecia. Next slide. Interstitial lung disease. We come to the last two: interstitial lung disease and LVEF. Can you go to the next slide? Again, if you see the incidence of interstitial lung disease, any grade which is higher, 15% versus 3%, and even grade 3 and 4, which have occurred in 1%, and grade 5 fatal events have occurred in 1.2% of the patients. Right. So cases of interstitial lung disease pneumonitis have been reported in TDXD, and patients were suspected of ILD pneumonitis were evaluated by radiographic imagings. Now, next slide. So if we see that the side effect, the main cough, dyspnea, fever, or new worsening symptoms, we have to any symptomatic grade 1 ILD, we have to consider corticosteroid treatment, and we should obviously promptly investigate these ILDs, and we'll have to check for PFTs and lung function tests every 3 to 6 weeks is something that we can do those tests, right? If these are asymptomatic ILDs grade 1, which we pick up on the scan, we can start with steroid, and if they resolve within 28 days of onset, then we can maintain the same dose. But if they don't get resolved in 28 days, then we will have to reduce the dose. For symptomatic ILDs, we'll have to give more than 1 milligram per kg per day of dose, and continue for at least 14 days, followed by gradual taper, and then we may permanently discontinue TDXD in these cases. Next slide. So again, suspected ILD pneumonitis, we'll have to interrupt the dose, get the test done, all high resolution CT, pulmonologist consultation, blood work, PFT, oximetry, and even PK analysis is possible. It may not be possible everywhere. Drug must be interrupted, and again, as we discussed, grade 1 less than 28 days resolved, we can maintain. Grade 1 more than 28 days it takes to resolve, then we reduce one step, and grade 2 or 4 permanently discontinue. Next slide. Same thing again reiterated. Next slide. So before beginning, we should obviously have a baseline function test, identify the risk factors. Risk factors being COPD, smoking, history of ILD. And in fact, even patients having higher creatinine or a renal function test, they also need to be worked up. So selection of patients to start on TDXD is very important so as to reduce the ILD incidences. And probably as the learning curve increases, we'll probably screen out those patients who have higher risk of ILDs, and real world data of ILD may be less than what the clinical trial has shown. Consider routine scans every 8 to 12 weeks, as I told you, PFT every 4 to 6 weeks. Encourage visits at multiple pulmonologists should be involved. Obviously, vital signs, oxygen saturation should be tested. 6-minute walk test can be tried every day or every alternate day, whatever suits the patient's profile. And encourage self-monitoring, ask the patient to visit the hospital for any symptoms. That's about it. Next time. Yeah, so last is the LV dysfunction. Next time. Again, LV dysfunction has been seen with most of the anti-HER2 therapies, but TDXD has slightly more than TDM1, 3% versus just 7 events versus 1 event. And 5.4 mg per kg LVF reported in 36 patients, that is 3.8%, of which 0.4 were grade 1, 2.9% were grade 2, and about 0.5% were grade 3. The observed frequency of LVF based on laboratory parameters, that is ecography, was about 15.9%. Right. So, and TDXD has not been studied in patients with LVF less than 50%. So initiation of TDXD in patients who already had a EF of less than 50% is difficult. And next slide. So obviously baseline LVF should be with LV strain pattern. If we can, if we can do those ecograms wherein we have LV strain assessed, that helps. And in case of LVF less than 40% or absolute decrease of more than, so this we'll discuss in the next slide. Can you go to the next slide? What to do when it decreases? So LVF, this is a classical slide where a lot of information, more than 50. So grossly, if you summarize, LVF more than 45% or an absolute decrease of less than 10 to 20%, then we can continue with TDXD. If LVF is 40 to 45%, then we have to see whether it is less than 10% decrease or 10 to 20% decrease. Then if LVS assessment in 3 weeks, LVF is not recovered to 10%, then we have to permanently discontinue. If it has recovered, then we may resume the same dose. So these guidelines are there. We can step by step look at the guidelines and treat our patients accordingly. So main point is, if the LVF is persistently low, below 10% of what it was prior, then we may have to discontinue the therapy. So if less than 40% and absolute decrease from baseline of 20%, then permanently discontinue and repeat LVF. And if there is a cardiac failure, that is congestive heart failure, then obviously we'll have to permanently discontinue. So when to discontinue is important. We'll have to repeat 2D echo every 2 to 3 monthly and see what is the function that is reduced. So we'll have to quantify the function. 10 less than 10, 10 to 20, more than 20. More than 20% reduction. That is, if it is 60%, 20% of 60 is around 12%. That is, if it goes below 48% of EF, then we'll have to see what we'll have to reduce the doses that way. Next. Right. So adverse events commonly experienced with TDXD in clinical trials are mostly grade 1, grade 2, may be managed through supportive care. Early reporting of symptoms essential in implementing robust management plan, optimizing treatment outcomes, and patients should be encouraged to report any symptoms immediately to their HCP. So it is definitely there are symptoms that are there. Probably in a clinical trial, you may notice slightly higher incidences because patient selection criteria is there, but in clinical real world setting, we may select those patients based on clinical judgment that may help reduce these side effects. Next, I think that's it. Thank you so much for patient hearing.
Thank you so much, sir. Moving on to the panel discussion, it gives me great pleasure to invite our moderator, Dr. Anbarasan Sekar, medical oncologist from Mumbai. Over to you, sir.
the AstraZeneca organization for this meeting. Good evening, everyone. Welcome you all for this panel discussion. I welcome all my panelists, Dr. Satyajit Pawar, Dr. Supriya Rao, and Dr. Aman Chaudhary, and also Dr. Uma Dandi. So I hope everyone there. My screen is visible.
Yes.
Yes, it's visible. Okay. So yeah, we quickly go over the discussion. So today, basically, our part is to discuss regarding two different case scenarios. And in this, not only we are going to discuss about clinical parameters, we are going to touch about laboratory parameters wise also, and then we are going to continue with the clinical scenario. So this is the first case. She is a 37-year-old female, presented in 2014 with right-sided breast lump, with tumor size of 5 cm, no lymph node, and no metastasis. Biopsy was suggestive of invasive ductal carcinoma, grade 2 disease, and ER was 70% positive and PR is 70% positive. Fish is IHC 2+ and fish is amplified. And she was received NACT followed by conservation surgery, radiotherapy, and tamoxifen she received. And also she received maintenance trastuzumab for 1 year duration. After around 5 years of duration, she presented with severe back pain. I think she lost to follow-up also. Almost 10 years बाद she presented with severe back pain and MRI suggestive of bone metastasis. And this is a PET scan. The lung fields are showing large lesions, and then liver also is showing multiple metastases. Biopsy was done. Biopsy suggestive of ER is 90% positive, ER 85% positive, and HER2 is IHC 1+, and we did fish also, fish tends to be negative. And Ka 67 and test is 60 to 70. So with this, how often does HER2 status change? So Dr. Satyajit, what's your opinion regarding change in HER2 receptor status, specifically with HER2 receptor status?
Yeah. So with HER2, if you are using a powerful antibodies like trastuzumab or pertuzumab combination, I would say around 40% of cases you will see HER2 loss, while HER2 gain I would say we will see in less than 10% of cases.
Dr. Suparna, your opinion?
For the change in HER2 status, I think I have seen few patients, probably 1 to 2 out of 10. There is a change, I guess, from HER2 positive to negative. Yeah.
Okay, so I would like to put in a difference, like how many number of patients from HER2 positive change to HER2 negative? How many number of patients change from HER2 negative to positive, which is more common in your practice?
HER2 negative to positive, I don't remember seeing any patients in my practice, but HER2 positive to negativity, especially post-treatment with anti-HER2 for first line, in the metastatic setting, I've seen them turning out to be TNBCs on repeat biopsy.
Okay, so yes. Dr. Aman,
Yes,
your
sir.
opinion regarding this HER2 status?
Exactly the same. The disappearance of HER2 at the progression does usually occurs in say 35 to 40% of patients. I have in my clinical practice I have not seen the HER2 negative change to HER2 positive, but definitely have seen patient changing from HER2 positive to HER2 negative. Roughly in the tune of say 30-35%.
So that's a quite significant number. So with regard to HER2 status, with the arrival of newer antibody drug conjugate, we need to change the definition of HER2 status. It is no more dichotomous variable. It is no more HER2 positive and negative. It has subclassified HER2 low, HER2 0, and then HER2 negative. So the HER2 changes drastically seen in the population from HER2 0 to HER2 low. This is the subset where the changes predominantly seen in those subgroup. Whereas when the patient is HER2 negative, that is either 0 or low, turning to positive is less than 5%. But whatever the 30 to 40% range we are discussing is mainly seen in the HER2 low and HER2 0 subset. So we have, I think we can, this discordant we can discuss in different area, different subset. Like when we do biopsy from the primary tumor site and biopsy from the metastatic site, is there any difference in the change in HER2 status? Is there or not? And we can see discordant in terms of de novo metastasis as well as secondary metastasis. For example, if the patient presenting on day 1 with metastasis and we are doing biopsy from the metastatic site, what will be the HER2 receptor status? Or if the patient treated in a localized or loco-regional disease and then quite sometimes afterwards they are presenting with metastasis, what is the comparison between the metastatic site of de novo and secondary metastasis? what is the discordant rate, whether it will be similar or it is different. And when we see about discordance, this discordance is applicable only to the hormone receptor positive subtype, or it is applicable to triple negative subtype also. And whether the discordance vary with site of metastasis. I think in general, everyone will agree in terms of site of metastasis, because bone metastasis is one area we may not be able to pick up the number of metastases where we usually feel discordance is always there. And lung and liver mostly concord with the site of metastasis. And there are certain studies which shows that liver metastasis and CN metastasis are far more HER2 positive compared to HER2 positive in the sense it may be from 0 to low, 1 plus or 2 plus, compared to 0 or 1 plus in the primary side. So that possibility is there with respect to site of metastasis. With respect to molecular subtype, we don't have any major studies which is showing any difference in terms of molecular subtypes, whether it is HER2 hormone positive cancer, where the changes is there or not, there is not much difference. And with respect to primary site and metastatic site, I think always the dilemma happens when the patient presenting with metastasis, whether to do a primary site or metastatic site. Whether we get any difference by doing it metastatic site is there or not. That is where I would like to discuss more in terms of topic here. We have 3 articles.
Sorry to interrupt, sir. So
yeah.
requesting you to also invite Dr. Prabhat Bhargava in the panel discussion, sir.
Yeah, sure. I also welcome Dr. Prabhat sir to this discussion. So we are discussing regarding mainly the role of metastasis, HER2 receptor status changed between primary tumor site and metastatic tumor site. Sir, your opinion regarding this change in HER2 status with respect to primary tumor site and metastatic site, any difference if you do biopsy from primary tumor site and metastatic site?
Yeah, so as everybody, all the panelists have agreed, one mentioned that there is hardly any downgrading of HER2. There is hardly any upgrading of HER2, first thing. And the difference between primary and metastatic does sometimes depend from where we are biopsying, whether liver are more predominantly HER2 positive and bone is predominantly hormone positive and HER2 negative. So, but hardly ever, this majority of times I have not seen discordance. So I hardly do both the side biopsy.
So I also totally agree with all panelists, but this discussion is more in terms of HER2 changes turning from positive to negative. It is not that way. This discussion in terms of changing from HER2 status from 0 to low, that is also considered as discordance. If the patient is having initial site is 0, if they are turning to 1 plus or 2 plus, either in the metastatic biopsy, it is considered as discordance. And it is why it is so important, because we have antibody drug conjugate. Antibody drug conjugate will be effective if the patient is having 1 plus or 2 plus. If it is 0, it won't be effective. That is where the discordance part coming into the picture. And we are evaluated, certainly, if the patient is 0 or low, turning into 2 plus or fish amplified or 3 plus is only less than 5%. But patient turning from 0 to 1 plus or 2 plus and fish non-amplified is certainly high. There are 3 different studies which is showing range from 30 to 50% is there, from primary site to metastatic site. And when the patient having de novo metastasis with secondary metastasis, there also the difference is there. The likely reason they are coding is might be because of the genetic drift happening in the site, because we all know that whenever the HER2 expression is there, the tumor behaves slightly aggressive in nature only. Because of effective target therapy, the survival is similar. But in general, if the HER2 expression is there, HER2 enrichment is there, the tumor tend to behave aggressively. So that is one reason why when the patient is having metastasis, that time the HER2 enrichment happening. That is not to the level of HER2 3 plus, but low HER2 positivity is there from 0 to low positivity is always there. It ranges from 30 to 50%. So this part of thing we need to suggest. But as of now, in all the 3 studies, all are 3 are retrospective study. This is the one study which published in Italy by Tarancio, where this studied that primary metastatic site, when this HER2 0 plus, the change to HER2 low is almost 44%. And even HER2 low tumor, the change is almost 22% is there. So there are slight differences there. So maybe in future we need more studies to confirm whether the change is happening in real world or not. But these numbers are significant, especially if we are using antibody drug conjugate, we need to have a look for this area. And with regard to discordance, which we discussed at the level of changing tumor site and other things, what will happen at the level of pathology? When we take the biopsy sample to the diagnosis, what is the chances of discordance at testing level? What are the factors which involve in discordance? Dr. Satyajit?
So basically, one of the important factor is the cold ischemia time. That as cold ischemia time increases, the receptor status on the tissue decreases. So there is more chance of getting HER2 negativity when the cold ischemia time increases in such cases. So it is important to process the sample in given period of time.
Dr. Suparna?
So I think I have to agree totally that how it's managed, how quickly it is done, and of course how good the lab is. That will all kind of determine how it's going to be.
Yes, I do agree totally with the panelists because the categorizing of HER2 is quite important in the antibody drug conjugate era because not only HER2 low and HER2 negative subset is there is something called as HER2 ultra low, which they are trying to analyze how we are able to incorporate so that we try to incorporate maximum benefit of antibody drug conjugate to the maximum amount of population. That is the idea behind it. So they want to categorize all the patients who are HER2 negative, and then they want to avoid all the inter-observation. By avoiding pathologically, there should be no sample error. The ideal cold ischemia time should be less than 1 hour, and the type of biopsy also determines how the sample efficacy, quality of sample will be there, and sample handling and the type of assay. We all know that there are different type of assay. Most commonly used is B45 assay, which is the most common assay that we use for IHC for HER2 testing. There is something known as HER2 sept assay, which is also equally comparable. So it also depends on what type of assay we are using. There is some German-based assay is there, and that is showing discordant state of 73%. So that also department, which is important. All these things are mentioned in whenever the IHC reporting is there. This should be mentioned in the IHC report. And with all this introduction, which I mentioned regarding what is HER2 low, HER2 negative, with the current definition of 2018 definition with pathologists, are there any gap in the current definition with respect to HER2 IHC low? Dr. Aman Chaudhary?
Actually, what I feel is the categorization of HER2 into low, negative, and positive. It's more of a subjective thing. Counting cells more than 10% exactly, there will be definitely interpathologist variation in that. And seeing a complete staining of the membrane and intensity of staining, all this appears to be subjective. So there is, I think this is the gap that all these measures are subjective.
Prabhat, sir, your opinion regarding this? With respect to 1+, 2+, we all know it is 3+, it is complete membranous staining, more than 10%. But with respect to 0, 1+, 2+, the definition is still not.
Agreed. It is subject mainly as per interpretation. People will say +1 or +2. Even for 3+, many times our pathologists say that it is as per the operator dependent. Many times.
So I completely agree with both my panelists because this is really true. In terms of HER2 negativities, that we never cared about what is there because it is negative. That is all. We are not going to target therapy. But the current scenario is little bit changing because we need to avoid this inter-observation because there will be more number of false positivity also there. There will be more number of false negativity also there. So how to standardize this method in HER2 negative setting so that the error rate will be reduced. That is what we are going to get update in our future scenario. So as of now, this is how we see. If it is 2+, there should be 10% weak staining, and the membrane will be moderate or surplus staining instead of very strong staining. There will be moderate staining, but it should be complete encircling of staining will be there. And for 1+, it should be at least more than 10%, and the staining will be weak and incomplete membrane staining will be there. Anything less than 10% and incomplete we call as 0%. That is what our current guidelines which we are practicing. But with the arrival of antibody drug conjugate and other therapies, not only with respect to Trastuzumab deruxtecan, we also have drugs like Trastuzumab deoxycarbazine and another one drug which is also showing response rate of fairly around 40 to 45% in heavily pretreated patients. So categorizing all these categories, which is very important clinically, so that we can provide the benefit of the drug to maximum number of patients. That is idea behind using this sort of classification. So with this, we know almost 55% of breast cancer patients who have low level of HER2 expression, and these patients tend to be HER2 low category. So with the use of more better definition, we may be able to increase this definition to include more number of patients into the possibility. We are done with the pathological discussion behind it, how we stain, what are the errors we have to go and get it, how the pathological way of assessment of HER2 staining going to get better and better in future, we have discussed. And we coming back to the case again, this is a recurrent case of, initially it was triple positive, and she treated with a good amount of adjuvant and neoadjuvant chemotherapy, maintenance trastuzumab, as well as hormone therapy. And almost after 5 years, she had a recurrence. And during the time of recurrence, biopsy with multiple site recurrence was there. ERPR is strongly positive, and HER2 this time it is negative. So with this, what will be your treatment option? Either you go ahead with chemo, or you go ahead with hormone therapy, or you go ahead with both combination of hormone therapy along with HER2 therapy. Dr. Suparna, your opinion regarding this?
I think so far I've just been giving hormonal therapy, CDK4/6 AI with ovarian suppression. That's what I've not been adding anti-HER2 therapy. Usually the patient has come
the
later with
previous
a mid
positivity,
yeah.
the report of previous positivity you won't consider during the time of recurrence. You will ignore that, or
Yes.
you want to recheck the biopsy again, or
No, of course we'll
still-
rebiopsy the patient and then check what it is. But on that, if the HER2 is negative, of course now HER2 low, we can always add EDXG also. But for HER2, if it's negative, in general, we have been just treating with anti-hormonal after
Okay.
oophorectomy. Yeah.
Dr. Aman Chaudhary, your opinion regarding this?
So actually, in this patient, I'll consider the previous report as the report which will decide my treatment plan. I'll consider this as
Okay.
HER2 positive only, because in between HER2 positivity and hormone receptor positivity, aggressive nature will be given by HER2 positivity. So if I target only hormonal by hormonal agent, there is great likelihood that patient may progress if due to some reason the patient was HER2 positive and it was falsely reported as HER2 negative. So I will not take a chance. I will treat with chemo and dual anti-HER2 therapy, and maybe I'll add OFS and also bisphosphonate, because this patient specifically had this bony mets as well.
Prabhat sir, your opinion regarding this? Would you like to change with
If
treatment
we're planning
hormone
to use
therapy
the
or
previous biopsy as a treatment decision, then why do a biopsy again? That's one of the thing. And if she has come back after 9 years, I would actually consider the current biopsy as my treatment decision. So I would consider hormone therapy only plus OFS. I would not consider anti-HER2 therapy based on current histopathology.
Yeah, agreed with panelists that after 9 years, I wouldn't go ahead with the previous biopsy. I would do as per the present biopsy, and as per present biopsy till now, we are not having adding anti-HER2 therapy till present standard of care. So anti-hormone therapy will plus or minus CDK4/6 inhibitor will be my choice.
But what is the panel's opinion if at all she would have recurred, say, in 12 months or a year and a half?
So in general, what is the opinion? In general, if the patient is triple positive, it likely it is not going to change the outcome. If your clinical phenotype is same, that patient is having lung and liver metastasis or brain metastasis, it is which is typically of HER2 positive breast cancer, then why you want to repeat biopsy? That is my first question. I think the question has been raised by one of the panelists, which is very true actually. Maybe the possible reason why the repeated biopsy is a long DFI. So that is one thing they might have thought of doing the biopsy again and then getting to the thing.
So if she had recurred within 1 or 2 years, then I would have not biopsied only. I would have just continued anti-HER2 therapy, or I would change my anti-HER2 therapy.
Yes.
But we do
Unless it
tend
is
to
some-
biopsy, right? Once there's a recurrence
Not,
But
in a year. I mean,
but as-
progression on treatment, that's different.
So it is not going to change. It is not a hormone positive cancer where we require repeat biopsy. We want to check for PIK3CA mutation or other hormonal molecular mutation profile. As far as an HER2 positive breast cancer, we try to treat if the clinical profile is matching. We try to consider as an HER2 positive cancer and we go ahead with the treatment. Very rarely we see the discordance. Whatever the discordant rates, which why we're discussing, is mainly for in the HER2 negative subset, 0 to low and other things which is happening in those subsets. In general, the shifting from HER2 positive to negative is less combination. And this is the expert opinion, which is done by all over the expert in the breast cancer all over the world. This is their opinion also. If the results of tumor biology in the metastatic setting differ from the primary tumor, it is currently unknown which result should go for treatment decision making. Since clinical trialing under addressing this issue is difficult to undertake, we recommend considering use of target therapy when receptors are positive in at least one biopsy, regardless of timing. So this was the expert opinion that majority of the people agreed. If the target therapy is at least positive in one of the setting, then we can consider that as a positive for the target therapy, and we replace target therapy in those settings. So after maybe the patient was started with chemotherapy with anti-HER2 therapy, and if it is the scenario, what would be your maintenance therapy of choice? Would you include CDK4 inhibitor along with anti-HER2 therapy, or you continue with anti-HER2 therapy only? Assuming that this patient has a shorter DFI, it is HER2 positive recurrence only, and then the patient continue with chemo and the anti-HER2 therapy. So what is the role of addition of CDK4 inhibitor and along with anti-HER2 therapy? Dr. Satyajit, your opinion?
So in Monarch, I think they have included patients who had received trastuzumab plus abemaciclib, trastuzumab, abemaciclib, and capecitabine. I don't remember exactly. Yeah. So patients who are receiving your first line anti-HER2 therapy, I would not consider adding the CDK4/6 inhibitor. I would continue my anti-HER2 therapy. Probably it will be a doublet anti-HER2 therapy with pertuzumab plus trastuzumab and an AI. At this point, as a maintenance, I would not add a CDK4/6 inhibitor.
Yes, I do agree with the Dr. Satyajit, because at this point there are ongoing trials are like there. Not only Monarch third trial, there are two more trials which are in ongoing study in the maintenance setting also, which is showing the role of addition of CDK4 inhibitors along with anti-HER2 therapy. But the results are not showing much. Results are yet to be released. Monarch therapy, we have the result. There is a PFS advantage is there, but there is no OS advantage compared to chemotherapy. So it is subjective only. If the patient you feel young, fit, disease burden is very high, or if the patient is having on maintenance therapy, if they're having slight progression in some or other place, like bone only progression is there, then you may try to twinkle that therapy. In those settings, you can utilize it. Otherwise, upfront maintenance therapy, adding CDK4 inhibitors, as of now, there is not much data. And if you are starting maintenance as A with anti-HER2 therapy, when you consider CDK4/6 inhibitor, I think I have discussed regarding this. What are the options at progression? If the patient progressed with anti-HER2 therapy, what will be your next option of choice? Dr. Aman Chaudhary?
TDXD will be my choice. So based on this excellent response, even in patient who have received pertuzumab or not, the TDXD will be definitely in my next choice. If the patient affords, otherwise TDM1, otherwise lab capsule.
Okay. I think with this we move on to the second case discussion, which is 48-year-old perimenopausal female presenting with newly diagnosed lump in her right breast, and there is no family history of cancer, and she is an nulliparous woman. And this is her initial workup, which is showing 2.4 centimeter solid mass in the right upper quadrant with no suspicious lymphadenopathy. And a core biopsy was suggested of invasive ductal carcinoma, and ERPR is strongly positive, and HER2 is 1+, and FISH is negative. And she underwent surgery. Tumor size is 2.4 centimeter, and the lymph node turns to be positive now. And current stage is T2N1M0, stage 2B. She's having good performance status, and she underwent surgery, radiotherapy, and adjuvant chemotherapy and other things, and followed by adjuvant therapy, adjuvant hormone therapy also she underwent. What will be adjuvant hormone therapy choice in current scenario? And as the patient is premenopausal, would you choose OFS or ovarian ablation? Dr. Suparna?
I think she's 48 years old. She must have completed her, family also. So definitely oophorectomy, and or if nothing else, if initially she's not required, at least GnRH analogs, and then plan a aromatase inhibitor. These 7 years is what I plan for in the adjuvant setting.
Okay, so she 3 lymph node positive. So would you like to add something in the adjuvant setting?
So I know there is data to add palbociclib and abemaciclib now, and ribociclib also, but no, in my practice, I have not started yet. Yes, she has 3 lymph nodes, premenopausal, I'm sure a high-grade tumor, but no, I tend to still not add aromatase inhibitors. I'm sorry, CDK4/6 inhibitors.
So, okay. How you choose between ovarian suppression and how you choose between ovarian suppression or ovarian ablation or GnRH agonist in your practice?
I think patients are willing for salpingo-oophorectomy. We do it, of course, not probably immediately after treatment. Then we start GnR analogs and probably 4-5 months or 6 months down the line ask for an oophorectomy. But oophorectomy would be the best probably bet for patients anyway.
Okay, I will
Basically discuss with them and then
if the
decide.
patient is less than 30, matlab patient is less than 40 or 35, you still go ahead with the surgery, or you counsel the patient to wait for some more time and then you put her on GnRH agonist.
Yes,
What would
then of course that young, then GnR analogs, and then see how things proceed, and then decide 2 years down the line. But definitely more than 40 completed family, then I would encourage for oophorectomy.
Okay. So I do agree with Dr. Suparna. So this is one area where we have to choose and we have to counsel the patient adequately and appropriately regarding how they are going to proceed with the therapy. If the patient is less than 40, definitely we have to put her on GnRH antagonist rather than going ahead with bilateral oophorectomy, because it will cause profound hypoestrogenism, which will not only affect it will have several impact in the patient's body. And one other study which is showing that there will be 40% risk of all-cause mortality. They have increased risk of cardiovascular mortality is there. So if the patient is very young, try to put her on GnRH antagonist rather than going ahead with bilateral oophorectomy in upfront, unless the patient is having positive issue of BRCA1 and BRCA2. That you have to see. If the patient is BRCA1 and BRCA2, then you have to advise for a prophylactic oophorectomy. Otherwise, wait till 40 years, patient get to the period of menopause, then you slowly counsel for bilateral salpingo-oophorectomy based on the type of this thing. And regarding the duration of AA, Dr. Aman Chaudhary, how you decide the duration of AA? 5 years, 7 years, 10 years? What will be your duration of choice if you choose for it?
Minimum of 5 years we have to give. We can extend beyond 5 years. We can go up to 7 years, keeping in mind that it will give
So
us
if
a
I'm
basis.
using AA, my question is simple. If I'm using AA, will you use it for 5 years, 7 years, 10 years? I'm not asking about tamoxifen. I'm asking about AA, aromatase inhibitor.
7 years, sir.
7 years. Okay. Not 5 years. Any reason? All cases used for 7 years, or you use in a specific scenario only for 7 years, otherwise you restrict for 5 years. Any data to support for 7 years?
7 years, there was a phase 3 trial, sir, in between 7 and 10 years. In between 7 and 10 years, it was seen that if we use it for 10 years, there were more bone-related events, but there was no difference in the overall survival. And in the MA17R trial, it was seen that if we extend from 5 years to 10 years, it was seen that there was a reduced incidence of contralateral breast cancer and increased DFS, but there was no overall survival benefit, and the bone-related events are more in the 10 years. So if we have to choose in between, I'll go with 7 years of duration of AI, given the benefit of DFS.
Yes. So I do agree. So we have two different settings of trial. Between choosing between 7 and 10 years, there are two trials are there. Ideal trial and ABCG 16 trial is there, which showed there is no difference between 7 and 10 years. Between 5 and 7 years, we have data with data studies there, which shown that 5 and 7 years, if the patient is nodal disease significantly positive is there, then there is a DFS advantage is there. In those subset of patients, you can use it for 7 years. And also, this duration is mainly if the patient is started with aromatase inhibitor, or if the patient is given sequential therapy, tamoxifen followed by AA in the beginning of 5 years, then only the duration will be 7 years if the node is positive. Otherwise, if the patient started with tamoxifen in the first 5 years, then there is an option for next 5 years you can give AA as a next 5 year option is also there. So if you start with upfront AA or sequential AA, you have to go up to a maximum of 7 years. And 7 years if the patient is not positive, 5 years if they are not having any high risk. So with regard to CDK4 inhibitors, so if you want to combine with and this patient has progressed after 2 years on letrozole, and this time this patient is having liver and lung metastasis and bone metastasis, what will be your CDK4 inhibitors of choice and any specific reason for it? And this time, if you would you like to choose change the endocrine therapy from letrozole to fulvestrant, or you still continue with letrozole? Dr. Satyajit, your opinion regarding this?
So patient who is progressing on AI, I would like to change my partner. And for patients who have significant liver disease, there is a subgroup analysis from abemaciclib trials. It showed that abemaciclib is slightly better in patients who have extensive liver disease. So my choice would be abemaciclib plus fulvestrant in such cases for this patient. Otherwise, we all know that based on different characteristics of these drugs, patients for GI toxicity or patients who have higher thromboembolic events, for ribociclib patients who have cardiac problems, then we have to avoid these drugs.
So, okay. So, my simple question, among CDK4 inhibitors, is there any data? This is the one of the best drug among the three you will pick up.
For first line,
leave about toxicity. There is no point in toxicity. We are just thinking, I'm giving an option of all the three drugs and patient is supportable for all the three and the patient is absolutely fit. What is the CDK4 inhibitor of choice in the setting?
For first line, I would use ribociclib because this is the only drug which has shown OS data.
Okay.
For second line, actually all three are same, so you can use anything.
So I would like to differ in a little bit in this scenario because I would like to divide in two parts. One is preclinical data and then clinical data. What we have in preclinical data? How the CDK4 inhibitors act. Abemaciclib is one which are apart from inhibition of CDK4 and 6, it is also having it also inhibit other CDK inhibitors. It inhibits CDK2 also. So in the sense, it is more potent compared to other two drugs. That is the only reason it is one of the only approved FDA drug as a monotherapy in this setting. None of the other CDK4 inhibitor has a monotherapy approved. It is always approved in combination. But when used along with the combination with endocrine therapy, there is no significant difference, at least in clinical setting. One area you can show the difference with ribociclib is the median PFS is very high with Mona Lisa 3 trial, but the caveat with the trial design is almost 50% of patients are treatment naive compared to Palomar 3 or Palomar Mona Lisa 2. There was almost 100% patient have received some form of other therapy in the previous line. So there is no clinical difference as of now, but preclinical data wise, abemaciclib has a slight edge because of two things. One is because of other CDK4 inhibition, and it has a better CNS penetration because it is not efflux by the it may not efflux by the efflux pump. That is another reason. And data wise also the things are little bit similar. And this patient was started with abemaciclib and fulvestrant, and this patient has developed with diarrhea and complaints of fatigue. So what will be your option as of now? You decrease the dose of abemaciclib and continue with the same treatment, or you withhold and restart? Dr. Suparna, your opinion?
I think I'll withhold till the patient's diarrhea resolves and then start at a lower dose.
Okay. So what point of time you will expect incidence of diarrhea when the patient is on abemaciclib? So you expect in the beginning only, or you expect of the patient once in 3 months, 4 months? When you expect diarrhea with abemaciclib?
I'm not too sure. I don't have experience with this drug.
So yes. So if dose reduction will it impact the survival if you reduce the dose of abemaciclib for side effect wise? Is there any data to support for dose reduction?
I guess it should not.
So the thing is that abemaciclib median onset of diarrhea is 7 days. So you have to call the patient in 1 or 2 weeks so that you have to assess for the diarrhea. And you can modify the dose as per the patient tolerance. And thus those tolerance modified dose is not showing any, it will not affect the survival of the patient. So we can always modify the dose according to the patient if the patient is having diarrhea. One advantage with abemaciclib is the incidence of neutropenia is comparatively less, but still the neutropenia side effect goes up to 50%, whereas with other two it is almost 70%. And good thing is whatever the neutrophils are remaining, it is functional neutrophils. That's why we won't get that much significant amount of neutropenia with these patients. And continuing with that, this patient has again progressed with CDK4 inhibitor also, with abemaciclib and fulvestrant also. And repeat biopsy is suggestive of again ER and PR positive and HER2 negative, and PIK3 is negative and BRCA negative. What is your next line of management? Prabhat sir, you would like to take this question? If the patient is post CDK4 inhibitors and PIK3 and BRCA is negative.
That's if possible PDX. If not possible, then we can continue hormonal therapy because if she's still not in hormonal visceral crisis, And if she's in visceral crisis, then obviously chemotherapy.
Okay, sir. Sir, any point of changing CDK4 inhibitor? Your opinion regarding changing from Abima to ribociclib or this thing, or changing the chemotherapy backbone?
I am not sure whether changing helps, but yes, continuing ribociclib, changing to ribociclib, there is a maintained trial which has shown that changing to ribociclib there is PFS benefit. But Palbe's trial where changing to palbociclib has not shown survival benefit. So changing to ribociclib does make a sense.
So I completely agree with Prabhat sir also. The scenarios changing from one CDK4 to other CDK4 inhibitor, there is a maintenance study is there where the first line of drug is Palbase is there and they change it to Ribase. There is a PFS advantage is there. That is a phase 2 study design, but the OS advantage is not there. So you have to see according to the patient status and then you have to decide accordingly. And I think there are newer drugs also coming up, like we have to check for ASR1 mutation, AKT mutation. The newer drugs like Enolisib or Capivasertib, it is working irrespective of the mutational status. That is also option which are upcoming in future. And third inhibitors we have Protect inhibitor. Vespotegib is one of the drug. Ongoing study is there in our institute also. We are going to study, which seems to work in those scenarios also. Maybe in future we get those options also in future. Otherwise, like suggested, if the patient in visceral crisis, we go ahead with chemotherapy. If the patient is affordable, then the option of antibody drug conjugate will be happening, either Saxatumab govitecan or TDXT. So with regard to Saxatumab TDXT, this is a trial which is Destiny 04 trial. And we all know that patient HER2 low receptor status has been enrolled into the study design. Both TNBC and hormone positive has been enrolled in a ratio of 2:1. PFS is the primary endpoint and these are the secondary endpoint, OS and the overall response rate has been assessed. And here, when we see the cohort, almost majority of the patients were hormone positive and they had very bad disease. 75% patient had liver metastasis, 30% with lung metastasis was there, and majority of the patient had treated with more than 3 or 4 lines are there. And target therapy with CDK4 inhibitors, almost 80% of patient has been utilized. In spite of all these things, this drug has shown PFS advantage, which is quite, we may not able to see in post beyond 2 lines or so to see this sort of advantage. PFS advantage is there with an hazard ratio of 0.51, which is very significant. And there is an OS advantage is also there with the median OS reaching up to 24 months, nearly 2 years. And this is how they divided and then see the OS advantage still maintaining for HER2 low population. And this is with regard to Saxatumab govitecan phase 3 ASCENT study design. They mainly included metastatic TNBC study population into the study design. And majority of the patients are used more than 2 chemotherapy lines in the advanced setting. They have been included into the study design. And the dosing is 10 mg per kg, day 1, day 8, every 20 days. And it is continued till the point of progression. Primary endpoint is progression-free survival. And this is overall, second endpoint includes overall survival. So at third line, this drug is showing PFS advantage. Very rarely we see in third line, the drug is showing PFS advantages. And that too, the PFS advantage is 3 times advantage is there. 1.6 months with the physician choice, it is tripled to 4.3 months, which is very less often we see in clinical practice, which is significant in that also. And it works irrespective of HER2 status. HER2 low as well as HER2 0, it tends to work. And there is an overall survival advantage is also there with 49% reduction with use of Saxatumab govitecan. And are we ready to include? With this, coming to the final conclusion of our panel discussion, we were discussing regarding the HER2 dichotomy, where we're changing from HER2 positive and negative. Are we ready to change into the other area, HER2 low, HER2 0, and HER2 negative? What is your opinion? I would like to ask every panelist opinion regarding this. Are we ready to change from HER2 positive and negative to HER2 low, 0, and positive?
So I would say I have at least started documenting patients like HER2 negative, HER2 low, and HER2 positive in my clinical practice. And I think we should all start doing that because we have already drug available, and in future definitely we'll be able to use it accordingly.
Okay. Dr. Aman, your opinion?
Exactly, sir. We have to start. I also at least I document HER2 low. It's 1%. I definitely documented HER2 low. And if it is 2+ and fish negative, I tend to document it because today the drug is not that much affordable, but maybe in future it will become affordable. So we should have this in our practice to note it down, because this has definitely a clinical implication, and in future maybe it will have more of that implication.
I think everyone will agree with the same, because this is the change. Very rarely we see drug coming into the practice. It will change the line of treatment. It is changing the diagnosis itself. So it is really one wonderful molecule only to describe, to change the category of the tumor classification entirely, putting the change in the classification. And there are ongoing studies are there. We are also part of one study, retrospective analysis, where we want to avoid the inter-observation error, especially in HER2 low and HER2 negative population. And we are also trying to manipulate HER2 ultra low. In zero itself, we are trying to put on a HER2 ultra low, and we are going to check how it is going to work in those subset of population also. So with this, I would like to thank all my panelists for wonderful interaction. It was very interactive and informative, and I would like to thank organizer for this opportunity. Thank you. Any doubts? You can go ahead with the doubts. Any questions?
Thank you.
If no more questions, we can end.
We request our attendees to put the questions in the chat box, if any. Sir, I guess we don't have any questions. I would like to thank all our speakers, moderator, and panelists for joining the webinar.